7. It's not possible.
The attorney is
if we don't have bylaws, if you feel like
yeah, it's true.
I mean, like, but he didn't have to call in, right?
We'll get him to.
he can sign out the bylaws.
But if you don't, you still need a form to then start. And then even with Chris calling in, we won't have 7. There's only 7 people that are on.
Thank you for.
Seems like an intense, we're like a 100%.
Yeah, but not as strange as some of the because
Yeah, that's
non-drug research. And I even
On the Terry, I asked that 7 out of 7 people. Yeah. And he voted yes to the bylaw. Do you want me to text him? But can we do it without part? That seems like a pretty nice message. Yeah, I think so.
You're more than welcome to stay.
Well, then we can start it.
Most of the notifications, applications, we've hit them.
You have a 10-year already for all of
But
it.
if you need a quorum, I'm not a member now, I don't think.
But the quorum is going to require 100% attendance. I think based on the fact that we're establishing meeting roster and establishing, I think, Shelley, I think we can base on the fact that we're trying to establish a meeting roster and establish bylaws that we can start, and then we have a vote coming in for bylaws, which is what will give us that, right? That sounds good.
No, you'll call it.
Okay, let's get started then. I am Julie Augustine. I am filling in for Dale Woolridge today, who's unable to make it, unfortunately.
I don't think I will be violating any.
Say why?
Yeah, confidentiality. Dale was bitten by a rattlesnake after our previous.
Which was our last,
presentation.
yeah.
Yeah, so, I'll wish him well.
To start with some quick roundtable introductions, I want to start with Ben.
Hi, I'm Ann Stafford. I'm the CEO of the Arizona chapter of the American Academy of Pediatrics.
I'm Kathy Lewandowski. I'm the Office Chief for the Office for Children with Special Health Care Needs in ADHS.
I'm Allison Mosley at the Bureau of EMS and Trauma.
I'm Ben Fisher. I'm also with the Bureau of EMS and Trauma.
Gail Bradley, Medical Director, Bureau of EMS and Trauma. Julie Augustine, I'm the EMS Medical Director at Phoenix Children.
I'm Julia Vincent, and I am the EMS for Children Coordinator here at ADHS. My name is Shelley Bissell, and I coordinate the stakeholder meeting.
We seem to be kind of agency heavy at the table here today. We're going to do our best to rectify that moving forward. My name is Terry Mullins. I'm the Bureau Chief EMS.
Hi, Debbie Johnston. I'm Senior Vice President of Policy for the Arizona Hospital Healthcare Association.
Brian Beard, Base Hospital Administrator for the state.
Tony Yuma, Director of EMS and the CAPCO representative.
And if anyone's on the phone, if you can introduce yourself.
This is Chris Ramos, Pre-Hospital Coordinator at Phoenix Children's Hospital.
This is Ray Proa, EMS Officer, Fort Molly Mesa Fire.
Joyce Hospital, Center for Rural Health.
Peter Como, Lifeline Ambulance, and Northern Arizona EMS.
That's it on the phone.
Shelley, Heather Miller from Kingman's on the phone, too.
Anybody else? Great. New EMSC Program Manager.
Yeah, so I guess I can just introduce myself again. So I was not at the last meeting. Obviously, we were department was in the process of hiring somebody to coordinate the MSD program, so I am now the person that is the point contact for all of the EMSD initiatives.
And then to announce and review our PACES membership roster. Do we have a handout that we included back from him? We have a lot of open vacancies. Our current chair and MD with Pediatric Emergency Medicine Fellowship is Dale Woolridge, who is not here today. We have representing the WAC EMS, Heather Miller. EMS is vacant. Should I just go to the vacancies? Just vacancies. Yeah. So a nurse with emergency pediatric experience, a currently practicing certified emergency medical care technician, a family representative, an NAEMS representative, and an AIMS representative, as well as a Southern Arizona EMS representative. And just to clarify, all the region representatives that went out to 4 regions based on when they have their meeting timing of those meetings is when they were able to actually elect someone to represent them on PACES. So we anticipate certainly by the next meeting that would be filled. But WACMS was the only one that had timed out in terms of when they had their meeting to be able to elect someone. So thank you, Heather, for joining. But that's why we do have the 3 vacancies from the regions, and all 3 regions are aware of that, and we'll hopefully vote on that within the next month and a half. That is Julia for your report. Yeah.
Okay, so you want to give the rule update?
Yeah, so good afternoon, everybody. Again, my name is Terry Mullins. I'm with the Bureau of EMS Trauma System. We are currently in the process of updating several different rule packages related to emergency medical services. One is the ground vehicle equipment and licensing process. Second one is for air ambulance licensing and certification. And we will have just begun the rule revision process for certificate of necessity programs. This is kind of an iterative process. We make the information broadly known. We ask for participation. And if anybody has not been notified of those rulemaking opportunities and you would like to participate, reach out to any of us here at the Bureau and we'll make certain that we involve you. We have slowed down the ground ambulance rulemaking for one of the reasons was we wanted to look at the EMS for Children equipment list. When this was in, the EMS for Children, as you recall, was in a different division of the Department of Health up until this past spring. As we moved it in, we reviewed some of the requirements of the federal program, including the equipment list, and it just so happens that we're updating our equipment list for the ambulances right now. So what we have done is essentially accepted all the recommendations of the National EMS for Children program. There's a couple of rash reasons in my head for that, in case you get a chance to review these. One, most of the equipment requirements are relatively low cost. 2, they benefit kids, and that's generally a good thing. And then 3, we want to the extent possible, support the National EMS for Children program and follow those standards where appropriate. However, everyone will have a chance to review that equipment list and provide feedback to us. But we wanted to incorporate essentially all of it at this early stage. We're also getting ready to update our scope of practice for emergency medical care technicians and other clinical care coordination items as part of our, what we call it, Article 5 rulemaking, and that's going to take place over the next year and a half as well. So we've got a lot of rulemaking opportunities going on right now. Feel free to help out. That's all.
And then I'll defer to Brian Beard for our discussion on the overview of the roles of base hospitals and EMS coordinators. And this is something that to keep in mind when we talk about the pediatric emergency care coordinator role later on in today's meeting.
Yeah, so the Bureau, we provide a certification for any hospitals wishing to become an ALS-based hospital. Part of those requirements are listed in Article 2. There's actually several requirements, several policies and procedures you have to maintain. First and foremost, you have to have an administrative medical director, which is usually kind of designated by the administration. And then you have a pre-hospital coordinator who is delegated by the administrative medical director to act on their behalf. So a lot of times the pre-hospital coordinator wears multiple hats. It's not just pre-hospital coordinator. Sometimes it's a trauma program manager. And they do various other activities. Another requirement of an ALS-based hospital is they have to have at least one written agreement with an EMS service. They're only required to have one. We have some hospitals that have 14. We have some that have one. But as long as they meet all the requirements in Article 2, they continue to be an ALS-based hospital. We typically do an audit every 3 years and go over everything to make sure everything's still in place. Some of the things that are needed is administrative medical director and online medical direction. Both of them have to be able to give online medical direction to the EMCTs. There is special credentialing requirements for the administrative medical directors and online medical directors that they have to maintain. It's all listed out. There's several pathways they can go to be qualified. Some of the policies and procedures that they have, I'm not going to list them all because we'll be here for a long time if I did. You have to have a communications, triage and treatment and transfer of information protocol and procedures. That's just a few. Medical record keeping, medical reporting. You have to have protocols and procedures on that as well. Controlled substance policies, storage, use. You have to have all that in place. You also have to do annual education, skills to maintain EMCT's competency within their scope of practice. There's also QA processes that the pre-hospital coordinators are heavily involved in. She's fun. The administrative medical director and pre-hospital coordinators are also responsible for special training requirements for the paramedics and EMTs. We do have some STRs that are in place at different hospitals, and those require special training and require continuing education and competency. So we do have special consideration and a specialty route for pediatrics. So, for example, Phoenix Children is a base hospital, and we have a route for them to go as well as our tribal facilities. So we finished our base hospital rules July 1st of this year. We made some changes along the way that I think are going to be beneficial to everybody to make things a little bit easier, especially with our tribal facilities. Previously, our online physicians and administrative medical directors all had to be Arizona licensed. With our tribal facilities, we found that they were having a hard time getting people in that are Arizona licensed, so a lot of people coming in and out. So now, as of July 1st, the online physicians do not have to be Arizona licensed on the tribal facilities. So we're hoping to gain more tribal facility-based hospitals. We've already had a few already kind of contact me and they're interested in it, so we're hoping that'll kind of come together, and I think it'll be a good thing for our hospitals, our patients, our EMCTs moving forward. So.
Thank you.
I'm going to stop now. I can talk for like 2 hours.
Does anybody have any questions? Okay, we'll probably talk about that a little bit more later on. Thank you. Okay. So triage, treatment, and transport updates.
So the Bureau just finished up a pretty large project to review and re-update the triage, treatment, and transport guidelines for all patients. Now, the way it works in Arizona, these are optional for any agency or a doctor utilize. So we have statewide treatment guidelines, but again, this is something that an agency can choose and their medical director can choose to use these or not use these. One of the projects that was put into place about 4 or 5 years ago when Dr. Gross from Phoenix Children's Hospital was here at that time, was really combining adult and pediatric guidelines onto the same page, which I think was a huge benefit. We kept that model and just really did some reformatting and updating these. So this is the newest version that has been updated and was approved at MDC last month, in September, I should say, actually, and went up on the web in October. We are still working on a finalized plan on how to keep up with these and keep them updated, but these are really good basis that any agency's medical director can choose to implement these. Some of the regions, Central Region is basically using a version of this where we are essentially taking out the verbiage specific to intermediates or advanced EMTs because they don't really exist in the Central Region, but the goal is to try to standardize care. So they're optional, but they are a really great resource, and huge kudos to Shelley and Allison in the room that did a lot of work on this. Thank you.
And these are publicly available on our website for anyone who's interested in reading or reviewing these. And we're still kind of discussing what the revision time frame will be. So if this is something that you're interested in, they get revised through 2 of our statutory and standing committee process. Those are also open meetings. It's kind of a long process to update these, and so they don't get updated super frequently, but we are kind of trying to figure out.
So they're guidelines, but do you know how many programs adopt them? 50%? 70%?
The old version, I don't think anyone adopted.
Okay.
The new version, I anticipate in the Central Region, which is all of Maricopa County, part of our Pinal and Gila are part of Central Region. I think the vast majority of agencies will end up adopting a version of this. Again, just taking out, maybe if you want to scroll down to probably page 6 or 7 on that.
All right.
Just to kind of give an example. Perfect. So that'll work. So the Central Region does not really have AMTs or AMTIs, so the really only substantial change was essentially just moving all of the treatment under AMT underneath paramedic and any reference to EMTI taken off. But other than that, the Central Region, I anticipate the vast majority adopting these as of January.
All right. So next, the review of the status of the EMSC performance measures. So if you're familiar with EMSC or at the last meeting, I believe that you kind of went over the 9 performance measures. But basically, if you're not familiar there, the EMS for Children program has 9 national performance measures, including, there's not a document on this in your folder, sorry, but including the hospital setting, the pre-hospital setting, and then more state regulatory kind of performance measures. So some of the ones that we're focusing on right now include the Pediatric Emergency Care Coordinator, so that's something that we'll talk about again later. But the objective is that by 2020, we increase 30% the proportion of EMS agencies that have a designated individual responsible for the coordination of pediatric emergency care. So that's something that I'm working on right now to kind of bring to you to facilitate the discussion of what that would look like in our state. Additionally, just to kind of also move on to the next agenda item is the National EMS Data Analysis Resource Center Survey. So this is called NADARC. They are responsible for collecting our data for the performance measures so that we know that we are working towards the national objectives. So that survey is going to begin this upcoming January and go all the way until April. And so that's something that we'll also be promoting among EMS agencies, both transporting and non-transporting agencies, to ensure that we're getting data from everybody across the state. In the past, data was only collected from transporting agencies because it's a lot easier for us to get a concrete list of those agencies. But we're really working on trying to include everybody in that.
I'm just going to jump in a little bit because from a historical perspective, because we did not count non-ambulance services earlier in Arizona survey, we're going to more than likely look like we're not as proficient as we used to because we're going to be surveying a much broader group of individuals. So if you've seen Arizona's results in the past from the National EMS for Children program, we're going to have it we're going to look like we dropped when in essence we're just really getting to the bottom of what the actual numbers are.
Yes, thank you.
Can you, for those of us who, I mean, this is my first meeting, could you send out the 9?
Absolutely, yes,
Yeah,
I will
great.
absolutely do that. Yeah, no problem. Thank you. Sorry, I should have brought them to the meeting.
It's okay.
About that. Then the last performance measure that I'll focus on is actually overseen by AAP here in Arizona, so that would be the Pediatric Prepared Emergency Care Program. Do you want to speak on that for a moment?
Sure. So the Arizona chapter of the American Academy of Pediatrics, we house the Pediatric Prepared Emergency Care Program, where we certify emergency departments around the state to be ready for pediatric emergencies. We currently have about 60% of the hospitals in the state that are certified. They become members and then they certify and recertify on a 3-year basis.
Yes. So according to the national kind of objective, we're actually above what they are wanting us to complete. So I think the objective says that by 2020 increase to 25% the proportion of hospitals that have a recognized that are recognized by part of a standardized statewide program, and we're already over 50%. So that's pretty amazing for us. So thank you, AAP.
Quick question. Is there an associated cost to the facility? And what has been your experience with the cost, even though it's small, being a limiting factor in pursuing that designation?
So we receive some funding to cover the cost. So there's a membership fee every year and a certification fee every 3 years. It's relatively small. The highest is $2,500 down to $500 because there's 3 different tiers. But we receive funding, grant funding, to cover those costs for critical access in tribal hospitals. So we really haven't had anybody, the conversation of cost has never really come up.
So I can add to that a little bit. I did speak to one hospital, rural hospital, who actually isn't designated in part because of the cost of compliance with some of the criteria. It had to do with some of their ED nursing staff and having to, and I don't know all of the details off the top of my head, but they had some staff who had been there, I think they were nurse practitioners who'd been there for a long time, who had treated kids, but because of, I think, some new certification criteria, they would have had to have replaced those staff, and in a rural area, they said they couldn't do it.
Yeah, so we would never ask them to do that. So we have a steering committee that oversees the program. So there's designated stakeholders from all the different organizations, the Emergency Nurses Association, the Arizona College of Emergency Physicians. We have the EMSP program has a designated position. So they look at that when situations come up like that, they look at how they can work with the hospital to make that work. So it's not you have to meet this or you cannot be certified. So they work with.
I'll go ahead and check with that CEO again and find out if that's been rectified. And if not, can I have them touch base with you?
That would be wonderful.
Okay, great.
So is it an ongoing annual cost or just one time?
There's an annual membership fee. The highest level for that is $1,500. And then there's a 3-year certification fee.
The reason I'm asking is because the Hospital Preparedness Program grant allowed hospitals to work with not only their coalition, their regional coalition, but to work with the department on, we set a goal to increase the number of hospitals participating by 5% per year, and probably why we're so high compared to others, because we utilize that grant program to help offset the cost. So we removed all the barriers. If I have a cost barrier, we have some grant money for you. If we have a training problem, we have grant funding for that as well. And so I think that collaboration and partnership allowed better participation, and we still have that ability. Just want to make sure that there's some connectivity with our coalitions, and we can work with Debbie on that as well.
And the other, what's also helped us out is the Access had the differential adjustment payment, but I believe that's going away next year.
No, so we've actually been working with them. So you're familiar, Access has been offering an increased payment for any hospital that holds certification. They're receiving a 0.5% increase on all Access patients hospital-wide. So it's not just pediatric patients, and it's not just emergency department, it's all Access patients hospital-wide. So obviously that more than covers the cost. We feel like we're struggling with communicating that to hospitals, because when if they're talking about the cost being an issue, clearly it's going to be covered by that increase. So we feel like if we could have partners help communicate that to the right people. It's continuing through 2020, and we're in conversations with them right now to continue it through 21.
Yeah, I mean, we've had those same conversations, and we have pushed this out to members, but I can just tell you that sometimes when they do that cost benefit analysis in terms of what it is that they'd be receiving with the differential adjustment payment to in this instance, the cost of replacing, it wasn't just the cost of replacing these nurses, it was really, these were folks that they had on staff for years that they just could not see doing this in a rural area.
And I will say, I've been the CEO for almost 5 years, and I've never seen the committee ask a hospital to replace staff.
But if you'd be open to coming to a coalition meeting in the future, or even our senior advisory committee meeting, to talk about that, that would be great. And one thing, and I promise not to derail your agenda any longer, but the Western Pediatric Center of Excellence was awarded by region to California. We participated in that grant application. It's a 3-year cooperative. It's significant money for the Western region, if you will, to continue to develop and enhance pediatric preparedness programs. And so we are going to be a part of that, and I think the Academy of Pediatrics here has a member as well, if I'm not mistaken. I could be wrong. I'm just one little pea in that big pod, but they're really focusing on getting designees from EMS and trauma within this Center of Excellence. So yeah, we're happy to be a part of it. California, Nevada, Hawaii, Colorado, Wyoming, a whole bunch of Western states. So, yeah.
Thank you. So moving on to discussion and action items. First, because we need a motion to discuss, amend, or approve the PACES draft meeting minutes from July 18, 2019. Can I get a motion?
The motion's done. Accepted.
One second.
On the July meeting.
I haven't looked here. The barcodes that are at 91s
are working?
Well, they don't have the date on them. On the board. I didn't look in the EMS
Can you
room.
please mute your phone? Sorry, if you're on the phone, please make sure you're muted. Thank you. Can I get a second to approve? All for? All for approving the minutes? Say aye. Aye. All against? Can I get a motion to discuss and approve the PACES draft bylaws?
Are these brand new, or were they edited after the last meeting, or?
They were edited slightly after the last meeting. For example, one thing that was changed, our EMSC grant requirements say that we need to have 4 meetings per year, whereas the Bureau operates on a 3 meetings per year schedule, so we'll just add an additional, probably, teleconference call just to fulfill that requirement.
We revised the membership to meet the national standard for membership. And we actually, and this is important, we shrank the voting membership to be consistent with the national group. Although, from an operational standpoint, all of the meetings that the Bureau manages are open meetings, and that has not been a problem. I don't think it's ever blocked people from participating, having a relatively small membership.
The categories in the bylaws, is that part of the grant requirement, or?
For the membership?
No, for the, whether you have parliamentary authority, open meeting law, minutes, motions, amendments, was that all the categories, or?
The parliamentary piece we copy from our other meetings, so we essentially use the boilerplate language from other committee meetings. We oversee the thing that we, in particular, are emulating the grant language on is the membership, and then we added the statutory language that covers our other committees usually refers to the EMS region. So the two things we kind of switched together to kind of keep the Bureau statutory language and then the grant language safe was the membership that's outlined in the grant and then the EMS regional membership for us.
I think Article 5 on, which is kind of the meeting section and parliamentary authority, those are the things that we have in place at the meetings, especially section 1 through 5 under meetings. That's something that we found is very effective in our other meetings where you have people that may be on the roster but never attend. We have a set process in the other groups where 2 consecutive meetings you get notified, do you want to continue to participate? And that way, if there's someone that maybe doesn't want to continue or doesn't respond, we at least can get people within the state that want to participate. Today's meetings, I think, were a great example. Before we had very robust participation from the public members that were in attendance both in person and on the phone. So it's worked pretty well, I think, for our other EMS meetings.
We want public participation. Yes. Bring your friends.
I just have a question. On the list of membership under family representative, it says grant required voting. Is that correct, or was that just a suggestion? Is it grant required? Okay.
So all of them that are designated as grant required, I think it was 8, I believe, are the core members required by the EMSG grant. So some of us are required, for example, myself and Allison and Dr. Bradley will fill positions that are required by the grant, but because we're employees here at the state, will not be voting members.
Looks like there's 3 voting members that are grant required that are physicians. Physician with pediatric training, emergency physician, and currently practicing MD with pediatric emergency medicine fellowship. We only have 2. So, unless we're including. So, and then,
Let me clarify that with the.
I wasn't able to hear what you said.
So, I mean, both Dale and I can meet multiple of these requirements, but it says physician with pediatric training, grant required voting, emergency physician, grant required voting, MD with pediatric emergency medicine
Okay, so I might
fellowship,
have missed
voting.
that. We might have missed that on the roster. There.
I don't know if they have to be different. Like, can I be pediatric and pediatric emergency medicine fellowship? Yeah.
I don't know. I have to refer.
Yeah, I will refer to the grant on that one.
I think on the roster, I think on the roster, you have it correct, but on the bylaws, we should probably need to line out and make sure those line up with the bylaws. So I think on the roster, there's 2 physician spots. There's emergency physician, and then there is START is required by grant. And then another was physician pediatric emergency medicine fellowship, and that's also required by grant.
Okay, let me clarify to make those 2 match up, and then, we'll see which one it is, and whichever, if we need somebody else, we'll push out for us.
How hard would it be to determine that?
Right now?
Yeah. No, I'm just, is it something that we can figure
it's
out during the
hard.
meeting?
Yes, if we look over. Would you like me to set that up here?
Because we're gonna have to vote on this, right?
Yeah.
Do you mind if we take just a moment to verify that?
This is a little unusual that we're trying to establish a meeting, establish bylaws and a roster, but that you need some type of forum to potentially vote on things. But moving forward, I think the process will be much more clean, but we want to try to get the bylaws and roster in place so that way moving forward for 2020, we have a nice set process for this. So thank you for bearing with us.
Can I just make one comment? You talk about statutory councils, and for me, I think the word statutory councils would be nice if it was in the second paragraph under purpose, where we say PACE accomplishes work in Arizona's advisory committee structure as a standing committee and I think those 3, the State Trauma Advisory Board, Emergency Medical Services, and Medical Direction, are those the statutory councils?
Yes.
And so for me, statutory council there first with the colon that says list who those 3 statutory councils are would make it more clear. It would be the second paragraph, second line. That makes sense? That you're really stating who those statutory councils are and you list them. And that's what I would add to that part there.
That makes sense.
Okay, this is what the grant guidelines are, so I think there was just an extra position written onto the bylaws. Remove that. One of the positions in the bylaws.
So the fellowship training, right?
Yeah, from the fellowship. Fellowship. Remove MD with Pediatric Emergency Medicine Fellowship.
It seems to be a good thing to have, though. I mean, we have it.
I think it was probably a recommendation that we made at the last meeting.
Yeah, that's probably why it was in there. So, however, I think
this one just says emergency physician. It doesn't say pediatric emergency physician.
right.
And we need the pediatric, yeah.
So we do have two
But I think we just have to clarify it, since it's not state required, I think it's good to keep it in the requirement for our committee.
Okay.
But I think you can, as long as we're okay with people meeting multiple roles. I think someone on the committee should have that. I have that.
Yeah.
I think we just needed to clarify that we didn't need 3 MDs on the committee, which we did.
So there's 2 components. We need to make sure we match the grant verbiage. So I think probably the cleanest thing to do, because this is somewhat tied to a grant, which is unusual, we don't have it with our other committee rosters, is to use the verbiage from this for cleanness. And then if someone fulfills that with additional qualifications, then that would be a nice addition. Yes. So that's kind of just to make sure that we don't ever run into issues where we haven't somehow met the grant responsibilities. I think if we at least make sure that the grant requirements are met is a key piece.
So for clarity, just because I'm having trouble hearing, which exactly bullet are we speaking about right now?
So in the bylaws, there were 3 positions listed.
Yes.
So we will remove the MD with Pediatric Emergency Medicine.
MD with Pediatric Emergency Medicine Fellowship is not required.
It's not required by the grant, so we will.
And, okay, so so the question was, are there 3 positions required by the grant?
Yes.
And we've determined that there are not, there are only 2.
Yes.
But then the other question was, is there a benefit associated with having the 3rd? That was a question. Okay. Then I'm up to speed.
We're going to take that one away.
And I think on the roster, we had fixed that.
Yes,
When
so
we
there
worked
were
on
only
roster,
2
the roster just
positions
didn't
on
match the updated,
Yes.
the bylaws didn't match the updated roster.
Okay, so that position has been removed on the roster.
So it will look like the roster.
Yes. Except the roster has, it says MD with Pediatric Emergency Medicine Fellowship is the title position on the roster, which is not an actual.
Okay.
It doesn't actually match.
Physician with pediatric training, I think it was extrapolated to include that. That is definitely an extrapolation.
Pediatric Emergency Medicine Fellowship.
I mean, both Dale and I have completed it. Actually, Dale has not completed a Pediatric Emergency Fellowship, which is fine because we're getting rid of that position anyway. He would just be, he fulfills either the MD with Pediatric or Emergency Physician.
Okay.
You want me to edit that out?
It should read,
Physician with pediatric training?
yeah.
Yes.
That requires voting member.
Yes.
That must have been how it was written. Okay, any questions on that or concerns, comments?
Yeah, I'm gonna just say something. Let's just make sure we capture this correctly. Everybody look at the screen. This would be physician with pediatric training.
Yeah, this should be physician, not
Yes.
MD.
putting together.
Okay.
And the EMSC guidelines state, is that part of the definition? Generally, so does this take us, this does not decrease the number of individuals, so we're still 13,
Yes.
odd number?
Yes.
Okay.
And then just so we make sure we capture the recommended language about the statutory committee, so back to page 1 of the bylaws, second paragraph, if you can just state again what your recommended verbiage, so we make sure that we get that correct.
I think in the second paragraph, it's read, functionally, PACES accomplishes its work within Arizona's advisory committee structure as a standing committee to the statutory, where did that go? Statutory council. And then like a colon that lists the State Trauma Advisory Board, the Emergency Medical Services Council, and the Medical Direction Commission. I think it just establishes that statutory that you refer to later on.
I'm lost for disclaimer people. So you're going to make that edit by hand?
Standing committee of to the statutory councils, colon, State Trauma Advisory Board, Emergency Medical.
Yeah, I've got it, Shelley, if you.
Okay.
Yeah.
So now we probably need a motion to approve the draft bylaw. I'm sorry, who was first? Debbie.
Debbie.
A second? Yes. Yeah. Thank you. All in favor? All against? Great. We'll have this. And moving on to the next action item, can I get a motion to discuss, amend, or approve the suggested pediatric emergency care coordinator job description? That's the next job description. Anyone want to make a motion to discuss it?
Sure.
Take it a second.
Position?
Yes, so I can give a little bit of background. So essentially, this is not its own position. Basically, the EMSC program promotes having an individual in an EMS agency or emergency department serving as somebody that's basically the point person for all things pediatrics. So if you look at the document or on the screen here, there's a list of what some responsibilities might be for the pediatric emergency care coordinator, but it's not its own position. It would be, for example, a nurse or a physician within that department that's also kind of serving as this part-time.
Because within the pediatric, this is going to be so confusing because the names are so similar and the abbreviations are so similar. So within the pediatric prepared emergency care program, we have the designated person that we work with that does a lot of these exact same things and then helps as the lead person on the site visits for the certification.
Okay.
This is specifically for within an EMS agency, right? Not a hospital.
So it can be, both, either or both. I think for this one, the focus would be on the pre-hospital setting. But when we were talking about the base hospitals, and Terry, you can kind of fill in with in this discussion, but you were suggesting that potentially the base hospital coordinator might be somebody that we could look to fulfill these requirements, if I'm not mistaken.
I think that's part of what I think as we get active with this is guidance from you all on whether or not the general scope of this position is consistent with how you think it would work in Arizona. The federal guidelines are the ones that are identified here. It may be that you all think that it should be one person per agency or not. What we're looking more for is to say, yeah, we agree that this is the flavor that we think would work in Arizona's EMS system. And for those of you who've worked in other EMS agencies, other states and EMS, I think one of the strong points of Arizona's EMS system is the base hospitals, because we have this coordination of quality improvement expertise at a hospital that works with many agencies, and those agencies have identified that that hospital plays that role on their behalf. And so it may be that you think that that would be a good home for the pre-hospital emergency care coordinator as we move forward. Certainly some agencies will probably identify an individual within their organization, but the base hospital coordinator is another place where this position may live.
So I'm like a little more context, like how this would interface with either like certification or with licensure, or, and it sounds like this might be one of your NAT 9 benchmarks. So I guess I'm just trying to understand more of a global.
Sure, and I just wanted to, we don't have to, have a finalized product necessarily, but definitely one of the performance measures that I would like to work on moving forward. So I can just share with you so our second performance measure, that's a national performance measure, all states have this goal that they're working towards, would be to increase the proportion of EMS agencies that have a designated individual responsible for the coordination of pediatric emergency care. So this can look a lot of different ways. For example, if you look at the job description, it could be a full-time individual, one individual with additional duties, a whole region might share somebody. So there could be one person that's just the point contact for a region or a number of different agencies, something like that. But essentially, it would just be somebody that would basically take the lead in pediatric-specific initiatives for that EMS agency or that group of individuals, whatever way they see fit. So really just kind of wanted to start the conversation in terms of how we might approach that in Arizona. So this says job description. It doesn't necessarily have to be like, here's your job description to one person, but more of a how will we approach that step here in Arizona.
But what is your position that you were talking about?
So we have the pediatric prepared emergency care site coordinators at hospitals.
Okay, so
and if that has the potential to overlap with this, I think we might need to talk about what with that, because I think it's going to be confusing.
Yeah, with a different name. And this is the name that is promoted through the EMSC program.
They're very similar. I mean, you're basically accomplishing the same. You're doing to make sure that hospitals are prepared to take care of children when they arrive to a hospital.
Mm-hmm.
This is making sure that agency is capable and ready to provide care to a child when they bring that patient to your hospital.
And in some organizations, maybe it's a shared position. Maybe they are the hospital position and the EMS position.
So I think that there's going to be a lot of agency opinions on this, because as like a pediatric-based hospital, we do a lot of these things already for a lot of agencies. We do standing PEDS education with AMR. We do it with Phoenix Fire. Like we do their CEs. We do a lot of this already, and we do. But I think to have a formal job as this, I think there's going to be agencies that want to keep that.
Julia, maybe one of the things that will help us is if we understand how the feds are going to measure it.
Yeah, so
because if we know how they're going to measure
I can tell you how they're going to measure it. So the survey that I talked about previously, the NADARC survey, that's specifically to measure performance measures 2 and 3, 2 being the pediatric emergency care coordinator, 3 being how they promote pediatric education. So they'll specifically ask, does your agency have a pediatric emergency care coordinator? And so yes or no would be the answer for them, and that's how we would get that data. And then there's a number of other questions that they would ask related to that.
Maybe the scope of this project is to help define what Arizona will accept as a PEs. Now, it's not regulatory, so this is
that's
this
not
is
trying to.
external to the regulatory
All
process.
voluntary. But yeah, what kind of things would we look for if I was to go to an EMS agency and ask them if they had a PEC, what would qualify, I guess, for that?
Actually, maybe I can speak. So one of the things that I think the Bureau has done really well with programs to try to encourage EMS agencies, there's different recognition programs we've done, the Premier EMS Agency Program. These aren't regulatory, but it's recognizing agencies for the work that they do. And so really, sometimes it's actually easier to implement things without the regulatory feature. We've had a lot of success. And I think speaking to what you were getting at, Julie, is that some agencies like to own things themselves. And so certainly, if the question is a yes or no, if you ask most agencies, they wouldn't know what that was. So the answer would be no right now. And I think, even if they're doing it, So one issue would be education of what that role and title is. And then the other piece is figuring out a way to encourage EMS agencies to want to do this.
Exactly.
Do you think that we have the ability to define it as we want to define it in Arizona?
Yes.
Or is there a federal standard?
No, so this document I compiled based on looking at documents from lots of other different states. And so it's kind of, the essence of what it would look like across the states, but everybody has a different job description, a different process. It's not something that is necessarily standardized, so I think that we can definitely make it into what we wanted to make it.
Is the term standardized?
So the term is standardized, yes.
Yeah, I mean, I think that the surveying on this could get tricky if you have one of these care coordinators who is maybe based in a hospital but is providing the scope of work for multiple agencies. Those agencies, who's ever filling out that survey may not know that. And so it might be that there's going to be where if there's a care coordinator identified, that individual is actually also communicating with the department as to which agencies they are providing coordination for. It just could get complicated if there are different paths for identifying a care coordinator and how that individual coordinates care. How many times can I use that?
So this is for the EMS agencies, not for the hospital.
Right. So
okay. So my suggestion would be to run this through base hospital with the base hospital coordinators, because they're the ones that are in control of EMS agencies. So unless this goes through the base hospital, the individual EMS agencies won't be able to participate unless they have some kind of duty from the EMS base hospital, their administrative medical directors. So this thing will probably have to run through them before it comes down to the agency level.
Okay. And before we do that, could we talk about maybe adding some clarifying language? Because I think if they got this right now, they would think this was our program, because the title and the description is almost identical.
And that's the same with your designation policy.
yes, so that's also another just kind of proposed, how do we keep, if we promote pediatric emergency care coordinators across the state, how would we keep track of them, or how do we identify them so that we know that they exist? Or is that something that we don't do, we just leave it up to the survey?
Well, if they're at the hospitals, that's something that we could help with. But I think we need more time than today.
An annual call with your hospital coordinators.
So that's something we're working on right now, because that's something that the hospitals have asked for.
I would be hesitant. I think the distinction between an EMS agency, pediatric emergency care coordinator, and like a hospital preparedness are very different. And so I would also be hesitant to say that hospitals should be the ones taking the lead on this unless it's a base hospital, because what goes into being prepared for pre-hospital care versus hospital care are really different. And so the goal of this is to actually make sure that EMS agencies are prepared. I think it does need to either be from the EMS agency or from a base hospital. And I think it's similar to everything else. I think either of those could fulfill that.
I think depending on the setting, whether it's rural or urban, and size of the agency is going to determine who is actually going to have that role. So in a rural setting or smaller, more agencies, this is more likely to be done by a hospital, or larger urban departments that may be done by the agency and not the hospital. So I think that's the tricky thing in EMS. There's different ways that people get medical direction and different ways agencies get medical direction. And so a one-size-fits-all sometimes doesn't really work for EMS.
Yeah.
And I think that's kind of what you're getting at, is that we may need to find a way of saying that there's different ways that an agency could get this role filled.
I'm wondering if one option, I'm looking at the membership here, we've named Ames, Lincoln, Ames, and I know we don't have all those positions filled right now, but it almost seems to me that it might be worthwhile vetting this through those EMS councils, the regional councils, because I think it might be different. I just don't know, have you already gotten any sort of feedback from the regional councils?
Can we just add EMS agency to the beginning of text?
Yeah.
That's what I wrote down.
I was going to say, EMS pediatric care coordinator.
Start with that. Yeah, and also that we're trying to prepare agencies.
At the national level, I voted against this national requirement. Not because I don't think it's a good thing, because I think it's a great thing, but we've got injury prevention coordinators, we've got trauma coordinators, we have base hospital coordinators, we have emergency department coordinators, we have a coordinator for every day of the week and flavor of the ice cream rainbow. And I'm concerned, and many of these people are shared positions.
Yeah.
And so one of my concerns is, how do we avoid driving these people to distraction and losing their focus? And I don't know how to do it.
Well, is this something that we think we should work on? Is it a good project, or?
I think you're required to.
It's like retractable, and it's important. I think the same way that most people have liaisons or representatives for other things. Like in our emergency department, we have a trauma representative, like a physician that's also the representation for trauma. Where there's cross. I think it's good for someone to be mindful of pediatrics within an agency. Hoping and actually on paper what's required, I think don't really line up here.
I think it takes a little bit more, I know you've done a lot of research on it, but a little bit more surveying and asking questions about how many other positions are out there that are like this. Because then I think that's what's going to tailor your job description.
Well, I can give you the results from the last NADARC survey if you are interested. So it was 77 responses were used in the data analysis. And so it says 22%, which was 15 of responding agencies, did say that they had a PEC in place. And then it was somebody asked recently if any of those were premier EMS agencies, and it happens to be that 11 out of 15 of those were premier agencies. So that's an interesting statistic. But so 15 out of 77.
Tanya, how would you handle this at your organization?
Again, you would have to go to our base hospital, and they would have to have knowledge of what this is, and then we will coordinate with our base hospital coordinator, which in our case is Flagstaff Medical Center. So after that, then that would decide whether or not we're going to participate. So, like she said, I think doing education on this with the 4 regional councils. I think you need to go sit in the regional council and share this with them. That way everybody has an idea of what this is. So it's just not just another position for them to put on them. And explain it to the regional councils so that they all know what this is.
Yeah, and I think that my thoughts in bringing this to this meeting was to get your thoughts on what was written first before bringing it out. To the rest of the councils.
Brian, how many base hospitals do we have?
48.
like, if we're gonna go at something like a base hospital route, is this standard, is this a requirement, pediatric care coordinator is responsible for these 6 things? Is that standard, is this?
No, so that's based on other documents. This is just an example draft. So if there's anything on there that you don't think.
As a base hospital,
it doesn't need to be on there.
We do 1, 3, 4, 5, and 6, but 2, there's 0, like, there's absolutely no way a base hospital can ensure that there's pediatric specific equipment, supplies, and medications available at the individual agencies. I can recommend all those things and help prepare you and encourage and promote. All the other things are okay, but 100% can never do number 2.
Is ensuring, is that part of the federal guidelines? So
That's my question, yeah.
Do you think that 6 is already covered under the PMD role? Do you agree?
So this is what what is pediatric committee? I mean, I'm going to try to think out of the box. Pediatric committee, what is that? Is that a committee within the agency, or could that be some other sort of committee?
What committee for?
I'm sorry. I said the pediatric emergency care coordinator in Arizona can be, and you've listed 6 different things here.
Yes, so these are all abstract ideas from other ones. So change everything.
So here's an idea.
Yes.
So, I mean, could this committee, if we were able to meet the scope, be designated as that so-called, that care coordinator?
For state.
For state.
But I think it goes back to this wording of the first, what is the pediatric emergency care coordinator? Because the last phrase of that is within an EMS agency.
Within the agency, yeah.
Okay,
I'm just.
Is that phrase, and that's the one sentence that's standard, right?
Yeah.
Okay.
And that's, yeah.
But if it's within the agency, and a regional approach may not work.
This actually has gone to the regions. It's been several years. This did go to the regions several years ago as kind of, hey, this is coming, and then the initiative lost a little bit of steam. And so people were kind of thinking ahead of how to prepare for that. Was to be thought that generally the Bureau strongly recommends or encourages programs. People tend to do it, even if it's not necessarily required. And so I think it's probably been about 5 years that this did go out to the regions with some support. I think to get buy-in, almost having a more narrow scope would probably be a better thing. It's really, what's the key thing you want to focus on is, improving pediatric safety and care. So what are some of those key elements that you include? But I think this has gone to the regions, and I think there would be an appetite to moving it forward. But I agree taking something to them with a little bit in a draft form is helpful, so you're not asking them to support something that they don't see. But I think the regions would have difficulty probably supporting something in front of them. So I think Julia's approach, which is to say, can we come up with a draft to take to the regions, is probably a good route to get buy-in. Just knowing kind of how they tend to work and improve things. But I think at the agency level, people, providers are nervous about taking care of kids. They recognize they need more training. I think there won't be a lack of support. It's just going to be making sure it's not an onerous process.
Dr. Augustine, you guys are a base hospital. You also provide administrative and online medical direction for pediatric stuff, right? We have 48 base hospitals in the state.
This is Chris Ramos.
Not
Just
that
to let
they
you know,
would automatically be interested in doing this, but that's an easy entry for us to capture a good portion of the EMS agencies. Is to, again, it would have to be voluntary, but work with those base hospitals that are interested in taking this on behalf of their contracted EMS agencies. I don't know if they'd be willing to do that, but that's if I were just creating the system offhand, that's how I would have looked, I think. Start there. Many EMS agencies will have will identify an individual within their agency, I think.
Terry?
Yes.
May I mean, obviously the language that you have here doesn't look like it fits with, when we're talking about the individuals that could provide that. they're not individuals that we're familiar with. Like as for an agency, you could say, could be a base hospital manager, could be a fleet manager, could be a training officer, you know. So those are actual individuals that are already in the agency, you know, or that they're familiar with. Because when you look at the, you know, the coordinator can be, you're looking at physician, EMT. I would think, you know, I don't think the intent is to create an actual full-time person, but rather than, you know, give these duties to another individual that's already in the agency. Because you're not going to get a great understanding of what this needs to be. And I don't think that you want to put it out there that, because it'll shut it down, or you need to hire somebody to do this.
We could also remove the word job and use like, I think that might also be
maybe position description.
Yeah,
you know.
or role, or I don't know.
Yeah, I think that's a really important distinction. I think this bullets are sort of saying all along that Arizona doesn't fit into like one. So I think if you use this as your chance to say it could be your base hospital coordinator, it could be an individual within your EMS agency, it can be a local, you could even have a bullet that's saying it could be this committee, it could be the AAP's like subcommittee, it could be any of these things as long as you have some designated, that's what we're trying to get at, right? That you have some designated approach to making sure that your agency can appropriately take care of and be prepared for kids. And so any of those, like if you want to use your base hospital, great. If you want to use AIMS, great. If you, whatever you want, like your agency, your local, anything, or AAP chapter, I think that would be a good way of saying any of these things can be utilized to meet this requirement.
So really what you're trying to get at is that the third section of pediatric emergency care responsible for that should be moved up. This is what we're looking to see if you're doing it. And then down below that is, here's the people that do this or can do it, like your, you know.
Who typically would be in this position.
But I think we should start out with what we want to see them doing and then say, here's the people who could be doing that for you now. You know?
Basically, can you identify someone that is capable of making sure you do all these things?
Yeah. And I think that might help to distinguish between, so if we list it out, like you were saying, it could be your PPEC site coordinator at your base hospital. So that's the way to distinguish between the two.
Yeah.
And then we might just need a little explanation, because I do think that's going to be confusing.
Julia, is there a requirement that they meet annually and have kind of a committee?
No.
I think that suggestion of maybe saying examples include, I think that's a great suggestion, because then it kind of opens you up to different options of who could fulfill that role, depending on the size of your agency and your resources.
And then it might be helpful to say somewhere that more than one, I do like the wording that says more than one individual can share these duties, or it can be, it doesn't have to be one. Because I think when you read coordinator and job description, you think that this needs to be one person. So even if it's just like an asterisk that says more than one individual can share these duties, or more than one individual or committees.
And then how do we keep track of who that person is with the agency? I think it's going to be important.
So that would be the second document.
Okay.
I mean, so I created, in addition to this proposed description, a kind of designation process. We don't have to follow this again. It's just kind of a proposed option, or we can edit it as we go. But this would be how we kind of keep track of those individuals and know who is designated in that role. And then if you wanted to look at that, this would all be after we decided who we would target with the job, with the role description, after we've kind of finalized that. But we can review that as well.
Can we change proposed role instead of job description? Yeah. Job description, I think, is
probably the biggest.
For word job.
Yeah.
I actually hate to recommend this because I'm starting to hate myself for doing it, but we do have a database where we could create this position in the database as long with our coordinator, fleet manager, and pediatric coordinator. All of these organizations are already in our database. It's just a matter of adding these positions to it. Like I said, I'm somebody that's in the database. I'm actually kind of hating myself for recommending it. And Ben is kind of...
I didn't recommend it. I thought it. I didn't say it.
Long term, it makes a lot of sense. Yeah. It makes sense.
It creates other problems, but it's like the only thing that we have that would be able to track that.
Yeah, and that would be using a pre-existing kind of resource. So the process that I propose would be basically creating a new database to kind of keep track of individuals once they have designated that individual. So
I have a shift at 3, so in the interest of just getting through, maybe a motion to just continue amending and discussing this document. Table it, yeah. Anyone want to make that motion?
Yes, I will tell make that answer.
Do we have a second?
Thank you.
Second, vote the, before we just go on, the job description and presentation process.
Yeah, basically C and D are both tabled.
And then real quickly, in the last couple minutes, do you want to talk about Safe Sleep?
Yeah.
Yes. If I can do that. So Dr. Woolridge who's our chair, who, again, cannot be here today, but he had really wanted to do kind of some sort of safe sleep education program for paramedics and EMTs. And so this would really be a super short, 30 minutes max probably, just training so that paramedics can know how to identify situations in which there might be possibility of unsafe sleep, or if they see cribs filled with blankets and stuffed animals, they're able to talk to the parent and say, this is not safe, here's what you should do, basically. So we, earlier in the education meeting, approved forming a work group. They approved of forming a work group with PACES to kind of address this. So this is the data from the most recent Child Fatality Review Report on SCID, so that just came out this past week, so just for your review.
So if you are interested in participating in that work group, please send Julia an email, and that will probably, we'll still wait to get participation from our education committee as well, and then when we have enough people, we will probably schedule a work group meeting to come up with kind of what that very quick educational module would look like.
Anybody have questions on that?
Can I get a motion? Yeah, can I get a motion to move forward with that approval for?
There's only 3 voting members, so don't feel bad if it's the same people seconding. Yes, okay.
Yeah, I move it, yeah.
Second.
Basically making up for all the time with staff that I never moved it.
Any, I guess all in favor?
Aye.
All against? And any agenda items to be considered for the next meeting?
When is the survey start?
In January.
So, we're doing it or
So I will be taking the lead on that. So, yeah, look out for information on the survey that will start in January, especially if you work in an EMS agency.
Public? Summary of current events, December 3rd through the 5th, we have the Navajo Nation Emergency Medical Services Trauma in the Boonies. December 13th through the 14th is the American Trauma Society's Injury Prevention Coordinator course in California, and March 2nd through 3rd is NAME's 11th Annual Arizona Pediatric Symposium in Flagstaff. And our next meeting is scheduled for March 19th, 2020 at 1:30 here.
Thank you all for coming.
Yeah, I'm just gonna take the